Okay. And okay, this, as all of you know, it is a collaborative learning community. So when we get to the case study portion, we just ask that everyone has their webcam on, their microphone on when you're speaking, and our breakout rooms after the case study will be the opportunity for discussion. If you have any questions during the presentation at all, please use the chat function, and we will have someone monitoring that. Okay, and lastly, if you could rename yourself to your name and where you work and your title if it fits. And to do that, you can just hover over your picture and click the three dots and then choose rename. All right, so now that we are done with housekeeping, just a reminder, this is Minnesota Project SCOPE. SCOPE does stand for Supporting Children of the Opioid Epidemic. And so our focus is on neonatal abstinence syndrome, which is the more broad name for substance abuse during pregnancy with the child. And then our focus will be more focused on neonatal opioid withdrawal syndrome, or NOWS. And most of our sessions are for early intervention providers who support children, and we are using the ECHO training, training model. And we do have a short video. Hopefully it works.
All right, I'm going to try and coordinate. The videos have been very finicky today. This is a video overview of the SCOPE model. Let's all cross our fingers and hope it plays. I'm going to try right now.
Children affected by the opioid epidemic and its related trauma have unique needs. Their families require additional support, and providers who support them must have the right tools to promote healthy development. Project SCOPE, or Supporting Children of the Opioid Epidemic, is an innovative national training initiative intended to standardize, develop, and expand educational practices to give providers the tools and the confidence to best address opioid-related challenges impacting children and families. Through collaborative video conferencing technology, Project SCOPE utilizes the ECHO model to bring together early childcare and healthcare professionals and other service providers. Outcomes for children, families, and early care systems will be improved through interdisciplinary education and skill development, especially in historically difficult to reach and hard-hit rural areas. Project SCOPE provides practical applications of advanced and real-time research findings. For providers, it means better knowledge and skills. For children and families, it means better outcomes and hope. Learn more at nti-scope.com.
Great, thanks, Jen. And as many of you know, we are using the ECHO model, extension for community health outcomes, which is really all about increasing access and sharing knowledge, as it said in the video. So we really want to create a community of practice and increase access to knowledge everywhere. And so our four core principles are technology, even not during COVID. It's always online to be able to reach everyone. We do use best practices. There's always a case study, and then our evaluations for data monitoring. And this is session 4 out of 8. So we are halfway. All right. And so now that we're done with welcome, I will introduce our speaker, and then we will do a case study and wrap up. All right, so you probably will recognize her. Our speaker today is Dr. Jennifer Hall-Lande. She is usually one of our facilitators. So Dr. Hall-Lande leads our early intervention work at our institute. She is a psychologist and a researcher with a specialty in early developmental delays. She does a lot of work around early childhood development and developmental monitoring. and is also a faculty of our UMN LEND program. She also leads the ACT Early project, and her work is committed to increasing access and reducing health disparities. Welcome, Jen.
Thank you, Courtney, for that nice introduction. And can everyone hear me okay?
Yep.
All right, wonderful. I've been having some interesting experiences with sound, but it sounds like I am loud and clear today. Welcome, everyone. It is so nice to see you. For some of you, I know it may be your last week of school. Others of you work through the summer, but either way, we are happy to have you. So welcome. I'm going to get started today. My specialty area is really working in child development and talking about early developmental delays. So today I'm really going to focus on that and the impact of opioid use while pregnant on the developing brain. And then I'm going to provide some resources today for us. And then I'm probably going to have a part 2 session, either this session or when we do a second implementation of Project Scope, another 8 sessions, where we really delve in and talk about resources. And one additional piece that I'm very excited about today, I'm going to have a early intervention provider and mom join my presentation at the end and share a bit about her experiences as well. So I will try and pack that all in and be timely and not go over time because I'll be in trouble with Courtney. But here I go. And I will take questions at the end, but you're welcome to put them in chat. I just can't see them till the end. All right. And I need to move my screen around just a little bit. So I know many of you, if not most of you, have been part of our previous series where we've provided a broad overview of the opioid epidemic in the United States. But just to give a little context, I'm going to start with that. So the opioid crisis in America is an identified public health crisis. It's been identified as an area of significant need and where we need to focus. Approximately 2.6 million Americans have an opioid use disorder. Now, I want to tell you a caveat. This data was collected in 2019. This was prior to the pandemic, but it's helpful for us to understand the context of this situation in the US. Use of heroin and pain medications by women doubled since 2009, and labor and delivery records indicate quadrupling of opioid use disorder among mothers since 1999. So what are our implications of this? Given the numbers, most of us who work with young children and families have worked with children with NAS or NOWS or with families that have an opioid use disorder. That is why it's so important all of us are gathered here today, learning together, working together to better serve children and families with opioid use. All right, this is a video. I am going to try my best. This video has been very hard for us to show, but it does tell a family story of opioid use disorder during pregnancy as well as neonatal abstinence syndrome. It's a wonderful video. I am going to try. It may or may not play. If it doesn't play today, I will play it for you for future, but everyone cross your fingers and I'm going to try my best. Here I go.
Great.
Is it good?
You are hungry.
So it's time for me to eat.
It's been a long road for Melinda Markham and her young son, DeMichael. She started taking opioids in 2012 after her daughter was diagnosed with cancer. The pain pills progressed to heroin. Eventually, Melinda stopped, but then started again after the death of her daughter at the age of 5.
It was like the worst it had ever been. I didn't realize I was pregnant until March. So from December until March, I was using.
Melinda eventually went into detox, where she was given buprenorphine, an opioid medication used to treat opioid addiction. In June, homeless, she showed up at First Step Home in Cincinnati, a residential treatment center where women live with their children as they recover from substance abuse.
Reality hits, and you know that you're the reason that's happening.
The opioid epidemic doesn't just touch adults. DeMichael was born in withdrawal and spent a month in newborn intensive care. His withdrawal symptoms were strong, and he eventually went home on a prescription to ease the muscle tightness, jitteriness, and inability to be comforted. Today, DeMichael is a patient at the Neonatal Abstinence Syndrome, or NAS, follow-up clinic at Cincinnati Children's.
There's that smile I've been waiting for.
Gail Hertenstein is DeMichael's nurse practitioner at the clinic.
Melinda keeps all of her appointments. We keep close tabs on him. He is meeting his developmental milestones, and he's doing great. He's doing great.
The NAS clinic provides developmental screening, occupational and physical therapy, and education about nutrition and feeding. As the babies become toddlers, they are evaluated for language and communication, behavioral issues, and overall development.
The long-term implications for, opiate exposure are still unknown. This clinic, to my knowledge, is one of the few nationwide that we have.
Everybody's talking about the heroin epidemic, but everybody's talking about the addicts. It was talking about the overdoses. And where were the children left in all of this? And if we don't address the children, then this is just going to go on.
Unfortunately, business is booming. In 2016, about 4% of babies were exposed to opioids in utero. When a baby needs treatment for withdrawal, the average length of stay in newborn intensive care is 16 to 18 days. And nationally, the average cost is $66,000.
Parental addiction is a very disruptive situation, and the child should not have to suffer because of that.
Each year, as many as 12,000 babies in the United States are born with fetal alcohol syndrome, and the results are devastating. Whether the same will be true for those babies born with NAS is something the clinic will be studying. In the meantime, the clinic is doing its best to get families help as early as possible.
Today is the 3rd. I had my son on the 3rd. I got clean on the 3rd. I am 8 months clean today. It works. It really does work. And it's such a better way of living.
All right. Thank you, everybody. I'm glad you could hear that okay and that could play okay. And I think it's a nice example of a family story, as well as the power of early intervention in the lives of children with NAS, as well as their families. And I'm going to talk a little bit about some things that were referenced in that video throughout, because I think it's a really nice example. But first, I'm going to take a step back and talk a little bit about early brain development. I'm going to focus a lot of my presentation on that today because I work a lot in early development. And some of this, if not all of this, is what all of you likely already know. You're experts in early intervention, but I'm going to do a quick overview of early brain development ever so quickly, and then talk about how opioid use in pregnancy affects the developing brain. So a couple things to know about early brain development with babies and babies that are still developing before they're born. But when babies are born, they're born with 100 billion neurons, approximately. They can learn almost anything. They come into this world ready to learn. They may be born here in the United States and speak English and live in an urban environment. They may be born across the world and speak another language. Babies come in ready to learn. Their brain is flexible or malleable. It needs to be. They don't know what environment they're going to have to adapt to and learn. And the brain is unique in terms of being an organ that it's, our heart comes fully developed. Well, pretty much, our lungs, but the brain is ready for experience. It has what we call plasticity at these early years when they're just born, and they're highly responsive to their environment. And I'm going to relate that to NAS in just a bit. So we say an early brain, an infant's brain, prenatally, it's wired to change and respond to the environment. We know from early intervention, this plasticity in those early years can make us stronger. We know things like good nutrition, early intervention, warm, attached parenting, they all help support a healthy brain, right? And the child needs that. They need that feedback. On the flip side, we also know that brain plasticity or its flexibility can make us vulnerable when we're very, very young and prenatally. And we think about things such as substances or viruses or being born very early. All of those can affect a child's brain development. So again, we know brain development, there's amazing growth and change prenatally and into the first 3 years. Any of you that have children or work with children, which I believe is many of you, you know they are learning machines. They are sponges. They are taking everything in their environment. You know, when a baby is developing, changes to the developing brain can occur in response to substances and exposure. We know that these brains are highly sensitive and wired to respond to their environment. So exposure to substances prenatally does have the potential to really cause changes in both structure and function of the brain. And I'm going to walk you through a little bit of that. So some of the broader things that we see in children with neonatal abstinence syndrome, you know, and I may use interchangeably neonatal abstinence syndrome and neonatal opioid withdrawal syndrome that's more specific to opioids. I'll probably use those interchangeably, just letting you know on the front end. But we know in research studies of children with NAS that it definitely has, for many kids, it has an effect on the visual center of their brain and retina. We often see working memory and memory issues and poor inhibition and control. For OTs that we have, you know, an abnormal sense of body and space and attention and learning. One thing I do want to focus on today, that all children are individuals. You know, we even know from the research that not every child exposed to opioids in utero develops NAS or NOWS. What we diagnose it on is observed behaviors. We know there's a lot of, just like with something like prematurity, we know there's individual differences, there's genetic and there's environmental factors, but I'm going to walk you through that in just a bit. One way, and I don't want to get too deep into the science and neuroscience here because we don't have a lot of time, but I'm going to give a brief overview of one of the ways that prenatal exposure to opioids or substances can change the developing brain. And today I'm going to talk about a little bit about neurotransmitters and what neurotransmitters are. And I hope people like hearing about the brain. They're chemical messengers that transmit a signal from one neuron across the synapse to another neuron. They give a message, and we're familiar with a lot of these. What we know is that prenatal exposure to certain substances can affect the functioning of neurotransmitters. And I'm just going to walk you really quickly. And I want you to think about this to make the links in terms of how prenatal exposure to opioids affects the developing brain, and then how in turn that relates to some of the symptoms and characteristics we see in children with NAS. So one, dopamine. I'm sure you've all heard about dopamine. So what we see in a lot of these babies is a decrease in the dopamine. What dopamine helps us with, and we're all aware, it helps us with planning and focus. It also has some functions in movement and memory. But in kids with NAS, what we see is a dopamine decrease. And so what we see is hyperirritability, anxiety. In the later years, and I'm going to share some of this research, we see challenges with focus and attention. We talk about dopamine a lot around ADHD and things like that. And I'll talk about later what some of the characteristics are we see. Another neurotransmitter that is affected in early brain development, serotonin. Serotonin helps regulate mood. It also helps with digestion. And one of its big roles is it helps with sleep. So when we see with a lot of these babies, we see a serotonin decrease. What that results in is poor sleep architecture. We see sleep fragmentation, sleep deprivation. A lot of these children we hear reports from caregivers, they just don't sleep, or their sleep is irritable, or they wake up a lot. They're crying, a lot of sensory issues. The other one, and I'll go quickly through these, acetylcholine, that one works with, it helps with regulating blood pressure, blood vessels, heart rates, muscle contraction. What we see is an acetylcholine increase, and we see symptoms such as diarrhea, vomiting, excessive yawning with children, with infants with NAS, excessive sneezing. And we often see increased body heat and temperature for excessive sweating. The final one, and certainly there are many impacts on the developing brain, but one, these are just a few, but the noradrenaline, sorry, I need to turn my phone off. It's dinging a little bit. We see an increase in those babies, and we see increase in temperature, tremors, faster heart rate and blood pressure increases. So we see if a mother is taking opioids, it does have an impact on her baby. I don't think that's new news to us. Some of the things that it does, some of the effects that we see in our brain when we take any type of a substance, obviously that can cross the blood-brain barrier, and we see some of these impacts in children. So the symptoms of neonatal abstinence syndrome, this is the Finnegan. I believe Dr. Precker talked about some of the characteristics we talk about on the Finnegan, or this is from some of the research they've done. But we see, again, in children that we diagnose with neonatal abstinence syndrome, some real issues with the central nervous system regulation, the high-pitched cry. We hear that a lot when we talk about that, a distinct high-pitched cry. Irritability, hypertonia, and then difficulty sleeping. These are all part of the Finnegan scale that Dr. Precker talked about last week that they use to assess neonatal abstinence syndrome. Again, not every child exposed prenatally will meet the criteria. That's surprising for people to hear, but exposure alone, they need to have these criteria of neonatal abstinence syndrome. We also see a lot of GI upset, disorganized swallow and suck reflexes, poor feeding, difficulty gaining weight. So we see weight loss, loose stools, and excessive spitting up. And then we see some nervous system components around that in children with NAS, increased body temperature, that's hyperthermia, nasal stuffiness, sweating, sneezing, yawning, and abnormal and rapid breathing. So again, that is sort of a broad overview of how we diagnose NAS. Often, again, commonly used tool is the Finnegan scale. A couple things to think about though. We know often that exposure to opioids with children with neonatal opioid withdrawal syndrome, it's just often one component of many other developmental confounders. One, we know that children exposed to opioid are at greater risk for prematurity. So we have the exposure to opioids, but then also many of them are born early. There's also intrauterine growth issues. A lot of babies are born low birth weights. I know some of you Part C and Part B people probably are connecting in some of the ways you qualify. I'm going to talk a little bit about that later. We also know from the research that if a mom is using opioids, there's a likelihood, a greater likelihood she's also using cigarettes or any other substance, alcohol, marijuana, any combination of these, that usually it's not just opioids, but a combination of several substances. We also, as we talk about additional confounders, consider parental education, poverty, parental mental health, and family genetics. All of those contribute to development and healthy development and how well the child does. And then sometimes it's hard to disentangle all of those. A lot of our previous speakers have spoken about ACEs. And then one thing you will see is that we intersect a lot when we talk about opioid use with many of the adverse childhood experiences. I need to spell out my acronyms, that we intersect with a lot of those and trauma, just generally trauma, and that a lot of those are pathways to some of the symptoms we see with NAS, such as regulation issues, increased anxiety, aggression, hyperactivity. And we'll keep talking about that. One, as a psychologist, I really feel it's important for me to talk about that children with NAS are at a greater risk for. It is attachment issues. The research tells us that the longer the mother and the child stay in the hospital setting, the greater the chance there's some struggles with attachment issues early on. We also know that in order to help build a healthy attachment, it's helpful if mom receives support in that area. If you think of some of the challenges of addiction, if you think of things like parental or maternal depression, those all can disrupt attachment. Also, if you think of things such as we talk about the vision, some of the vision challenges in kids with NAS, we see this picture here, we see this beautiful gaze between mother and baby. You think of how that can be disrupted. One, again, if there's maternal depression, or two, if a child can't regulate, stay still, focus on a gaze. So all of those things put children with NAS at a greater risk of attachment issues. So any intervention with moms and babies really needs to involve components for helping to build healthy attachment between mother and baby, and really the family and the baby. So I'm just going to do a brief overview of the research. You heard in the video that I played earlier today, we don't have a lot of research on the long-term effects of neonatal absence syndrome. More studies are needed. We really need to understand this better. It's impacting a lot of children and a lot of families, and we just don't know as much as we need to right now. Like prematurity, issues with NIS don't resolve with infancy. It is something that really affects the entire developmental trajectory. So it's not just that we go in and as early intervention providers provide an intervention at birth and then everything's okay. It likely would, the needs and the symptoms will go across different developmental stages. I'm going to break that down in just a bit. There's long-term effects. And we also need to consider things like the family, economics, genetics. You know, children are parts of systems and families and communities, and really need to take a closer look at that. And support may be needed through young adulthood. A couple, and I'm sharing a lot of data, and I cited at the end from the Boston birth cohort study. For those of you that are interested in research, or the researchers out there, it was a large population-based study. It looked at children and it followed them that had been exposed to opioids in utero, and it followed them with matched controls and took a look at what symptoms were they seeing over time that were more significant in children who were exposed to opioids in utero. One, and I said it before, low birth weight for age. That's an odds ratio. The way you interpret it is they were 1.87 odds higher, or I might say approximately 2 times higher. So if a baby was exposed to opioids in utero, they were almost twice as likely to be born at low birth weight for age. Prematurity, they were about 50% more likely. So again, is it directly related to the opioids? We don't know, because there are multiple risk factors with a lot of families, but it certainly increases the needs for these children. I also probably would venture to think that for some of you in Part C, you may bring some of these children in under the low birth weights. All right, so I'm going to walk us across developmental concerns. I do a lot of work in development as a psychologist, and I want to sort of trace this developmental trajectory across in terms of what it looks like and what the research has told us, as well as clinical practice of children with NIS. So from birth to 6 months, these really little babies, infants, we see muscle tone issues. We see delayed motor milestones. We also see some hypertonia, some stiffened muscles. It's different motor needs as well as delayed motor needs. We see a lot of sensory issues, high pitch, prolonged crying, not sleeping, as we said before, irritable, poor sleep architecture, increased sensory seeking behaviors and sensory needs. In some of our previous sessions, we talked about the swaddling, a lot of digestive issues. Again, that high-pitched cry, difficult to soothe. We're hearing that a lot. And then decreased self-regulation. Those are interrelated constructs. I bolded it because you will see that go across all of the developmental stages, but look a little different. So it really is a universal theme, this difficulty regulating themselves in their environment. What it looks like in infants may look different in a toddler and a preschool, but it certainly is a constant theme we see across development. Just keeping an eye on time here. Developmental concerns from 6 to 12 months. We continue to see delays in motor development, gross motor development, ongoing digestion and feeding issues. A lot of times children with NIS have difficulty feeding. They don't gain weight, difficult time keeping weight on. And again, and none of these fit every kid with NIS, and one of these alone doesn't mean you have it, but these are what the research is telling us are some consistent symptoms. Sleep problems, a variety of eye and vision problems, some hearing problems, and again, those atypical motor patterns, the writhing, the fidgety movements, back arching, really strict, stiff muscle tone. All right, developmental concerns, and I'm going to take us through preschool on this. So these are the toddlers, you know, early toddlers and later. we're seeing the speech language delays emerge. Not that they didn't have them before, but it's starting to really become apparent. This may be another way those of you in Part C and Part B bring in some of these kids. An increased rate of aggressive behaviors. Again, not every kid with NAS is going to hit or bite, of course, but we did see an increased rate in the research literature. Some head banging, ongoing sleep issues, some, and I will say the results are mixed on cognitive. In this particular study, there were lower cognitive skills on the Bailey at this age. One showed no difference, another study showed no difference at that age, but it certainly is something to pay attention to. Another area, potentially developmental domain to qualify in early intervention services, ongoing regulation issues. These are these toddlers into preschool. What the research and clinical work tells us, these are not necessarily my words, but some other clinicians and parents' words. They say it's like the terrible twos on steroids. So think of toddlers and all of the things they do, but with even less regulation, even more need for movement, some difficulty playing with toys, always moving, constant sensory seeking. And sometimes we do hear low response to sensory as well. Poor attention, poor sleep, difficulties in language development, tantrums, and hyperactivity were more common in the group with neonatal abstinence syndrome. These are the older preschoolers into kindergarten, and we see some of the same themes remain. The speech language, we start to see gross motor, but also fine motor. And some of that is because the expectations change. Once you're in preschool, they expect you to be able to do fine motor. So we're seeing delays in that way. Again, poor attention, and we continue to see some of these behavioral issues, behavioral regulation. In this, they said oppositional defiant. The Boston birth cohort followed past 6 years, and two of the most salient things they saw in the birth cohort of children with NAS was about a 2.5 times more frequent odds of ADHD, attention deficit hyperactivity disorder. That's that attention, regulation, impulsivity, as well as conduct and behavioral issues. Again, not every kid, but an increased chance. One thing I would be remiss, one of my roles that I play here at the University of Minnesota is I work in a developmental program. It's a public health developmental program called Learn the Signs, Act Early. It's all about monitoring healthy development and acting early if there's concerns. As I took you through the developmental milestones that sometimes we see with a child with NAS, a tool that you could use and promote with families are the free resources that are offered with Learn the Signs Act Early. I'm just going to share a few because in the interest of time, I want to make sure, although I think I'm doing okay on time, right, Courtney? Give me a thumbs up if I am.
Yep, you're good.
Okay. All right. So you can look this up. It's both a national program and we have a Minnesota version of it, but you certainly can Google CDC's Learn the Signs Act Early and see a wealth of free materials that they have that you can use in your teaching or in parenting. Our whole goal, we're not selling anything. It's to help support families, understand healthy development and act early if there are concerns. And we know that children with neonatal abstinence syndrome are certainly at a greater risk for developmental delays. Here's one tool that we have. You can pull it off that website. You've probably seen many iterations of this in different programs, but we have checklists. Some early intervention providers use these checklists, like in Head Start, to guide their conferences with parents of where they would expect typical development to be for, in this case, a 9-month-old, and where they're seeing development with the child. It's a great tool. You can print it off for free and get a hold of those. Many of you may be aware we have some wonderful children's books, again, free, and you can connect with us. You can get them. I think they're a bit out of stock right now nationally, but you can contact us and talk to us how you can get them for your classrooms. Some Head Starts and some preschools have given away these books to families at literacy nights. But what they are, and I have one here, you probably can't see it because I have my background on, but we have 3 books right now. One is called Baby's Busy Day, being one is so much fun. It's all about 1-year-old typical development, and also when you should be concerned and how you can act early if you do have a developmental concern. The Where is Bear on the corner is for 2-year-old development. What's typical with a 2-year-old? When should you be concerned if you're not seeing it? It's aligned with the typical developmental milestones for 2-year-olds. It's a wonderful, colorful storybook. And then Amazing Me, It's Busy Being 3. A lot of screening programs give that out. And it's about the typical developmental journey of a 3-year-old. And again, what you should do if they're not meeting those milestones. And I know many of you on here are experts in early childhood development, but we can't assume every parent knows. And we can't assume every parent knows how to access supports and services. So we love getting these books in the hands of families. We give them away at every chance we get, and they're a wonderful gift to parents, but also helps connect them to early intervention services if needed. And again, please chat into the chat if you need help knowing how to order those, and I can help you out with that. One thing we hear from parents, they definitely want tools to track their child's development, but not everything in paper. And so we do have a wonderful free app. There's not advertisements on it. It is free. It's in English and Spanish. You download it on your phone and you can track your child's development. I have a pretend child because my children are teenagers on my phone, and it gives typical developmental milestones, how you can support healthy development, how you talk to your doctor if you're seeing a delay. It has videos. I mean, it shows things such as joint attention, reciprocal play. It talks about attachment. It's a wonderful resource. It's free. You can go to the CDC or you can Google Milestone Tracker app. It's a wonderful tool and resource. I'm not going to get into this a lot today, but I know many of you are interested in this topic. And this will probably be in my more resource-driven early intervention talk later on. But one thing people have been asking about auto qualifier, and do any states automatically qualify children diagnosed or identified with NAS in ECSE? Is there any states that do that? And the answer is yes. The information I receive, but currently there are 12 states that list neonatal abstinence syndrome as a diagnosed condition with a high probability of resulting in delay. You know the language for eligibility for Part C. So the states are, and you can look at them, but Alaska, Arizona, California, Connecticut, Maryland, Massachusetts, Ohio, Rhode Island, Tennessee, Texas, Utah, and Virginia. Minnesota is not one of those, but I'm sure you do see kids with NAS or NOWS. They're probably coming in under a developmental or perhaps something like the low birth weight. It will be an interesting discussion. There's policy implications around it, but I'm happy to talk. I know many of you are interested in finding out more about these states that have chosen that path. All right, and here are my references and resources if you're interested. But I think I'm good on time. And so I would like to, and Sarah, you were here, correct? I'm going to introduce you, but I just want to make sure you're here. Hello, Sarah. I want to introduce. Hello. Yes, good to see you. I'm going to take it off while I talk. I'm going to take it off that reference slide. We met, I'm going to introduce you, but we had the pleasure of meeting you last session, and I was very excited. We have Sarah Beckman here. She is an early intervention provider with Independent School District 197. Yes, as you've renamed your, thank you. Also the parent of 3 young children, one of whom was born with NAS. And I am really excited to have Sarah here today because one, I think family stories are important. I think they teach us more than anything I could probably ever teach you in a PowerPoint. And number 2, Sarah came to us last week and shared some of her experiences because her group asked her to, because she had so much knowledge. And it perfectly models our goal in ECHO, that it's not just us teaching and sharing, it's bi-directional, that those of you participating also have expertise to share. And so after Sarah spoke last week, we asked if she'd be willing to come and share a bit with us today about her experience and her journey with her daughter, and some of what you experienced, and then how early intervention helped and what might be helpful to the people on our Zoom as they work with families and children with NAS. So I'm going to turn it over to you. I'm certainly happy to kind of do a question and answer, but I also know you have an abundance of information and you also have a good amount of time if you would like to use it.
Oh, 15 minutes.
It's 3:40 and I think we have about till 3:55. So you are
wonderful.
15 minutes, but we would love to hear your story. And I'm going to watch chat while you do that.
Perfect. Yeah. So just some background is my husband and I did foster care, and our very first foster placement was a baby who was born and identified as having NAS. She came into our home. Well, we picked her up from the NICU at 6 days old. And so, you know, the NICU and the nurses were wonderful, and they, you know, really kind of broke everything down for us about her care, her symptoms, and she did not need to leave the hospital on any medication. She was having some withdrawal symptoms. And again, it was very interesting to me because NOWS was not she was exposed to opioids, suspected alcohol, cigarettes, marijuana, and then opioids. But NOWS was not a term 5.5, almost 6 years ago. And so it was interesting to learn that a couple of weeks ago. But so she had some withdrawal symptoms that we were monitoring as we took her home. You know, some tremors, high tone, sleeping and eating difficulties. You know, but really at that 6 days old, that was about it for her symptoms. She had more in her first 6 days, but they had kind of resolved, some of the diarrhea, those types of things. But when we took her home at 6 days old and getting our bearings, at 12 days old, she had a seizure. And so we were back, actually, they took us back to the NICU where she was previously. And because she was in our home as an out-of-home placement, you know, it's just been very interesting to think about the parental side of this. And again, as an early intervention provider, I have not had a parent, but I have worked with quite a few foster parents of babies with NAS. And so we came home. Anyway, so we're back in the NICU and she had a seizure. So they did some more testing. We were in the NICU for 5 more days, monitoring those withdrawal symptoms. So she is now almost 5.5, or she's 5.5, going to be 6 in September, and continues to have, I felt like when you were going through the developmental concerns of 0 to 6, 6 to 12, it was like we were about 80% hitting the mark for those things throughout her entire development. And so again, very interesting how looking at, she was low birth weight. She was born at 36.5 weeks and was 4 pounds, 7 ounces. And she's incredible. And I'm just trying to think about what else. Oh, early intervention. So we were, because she was in an out-of-home placement, she was an automatic referral. Most of the counties in our area, I don't know if it's statewide, but most of the counties do automatic referrals for children under the age of 5 to help me grow into the early intervention programs. And so we spoke with someone before we were even out of the hospital the second time from our school district that we lived in, and started the evaluation process. She was easily qualified because of her seizures, and because her EEGs did show that irregular brain activity, and we were able to get that kind of as an easy. I don't know. I think that is something that is that challenge when we're looking at kiddos, and especially when they're so young, for qualifying and making sure we're keeping tabs on their development. And so we did have that. We were working with an early intervention provider out of Burnsville. She was amazing. And, you know, in the beginning, we kind of checked in once a month. And as her development started to show more of those delays, it really, we increased our time with her, really spent some time getting connected with the county for some supports. But we ended up with kind of I always say her story is like she would make these huge gains and then we would have these big dips, and it was like her developmental trajectory wasn't just this like learning skills. It's like she'd learn something and she'd forget something and then she'd learn something new, and it's like as we're having these big motor concerns, she'd, it was just, I feel like as a parent, and again we were her foster parents at the time, she's now adopted, but I would always be like she's doing so awesome. And I know as a parent, I know that those are like yay moments, but then as an earlier mentioned, I'm like, okay, well, we're just gonna keep watching and different things. And so the first 5 years of her life, it would be these like hills and valleys with her development. And we have had off and on PT, OT, speech, neurology, like every provider pretty much. And I just am so blessed that we live in Minnesota and that we live in a place where supports are available. And I know that that is harder in some of the rural areas, but this training is amazing. But I feel like I could just talk about her for forever because she's amazing. But if there's any specific questions about her early intervention, different developmental stuff from birth till 5.5, anything, I'm kind of open to kind of listen to specifics, questions from you, Jennifer, or the group.
Yeah, thank you so much, Sarah. I love hearing about it, and I love hearing she's doing so well. And I also appreciate, so much of what you mentioned, I think ties into what we talked about today, just some of that uneven, it's not a typical developmental trajectory, but she had gains. I hear that from quite a few parents. Last week, you talked a little bit about some of the interventions for your daughter that were most helpful, some early intervention. I think you talked about the wet swaddle and a couple other things. What were some of the things that you think about? Obviously, I know some of that goes into the medical arena, but what were some of the things really helpful?
Yeah, so when she was an infant, we definitely used the swaddle bath to help with the kind of bath and then the soothing, because she was so, not always, but often difficult to soothe. Just speaking about infancy, we, obviously we tried to keep our home very calm. We would keep things fairly understimulating with the light and noise and different things. But then at the same time, trying to expose her to new things. We don't want to just keep her in a bubble for forever.
Right.
And as she's gotten older, the sensory piece has been huge. She has a lot of sensory sensitivities to noise, but then she's a seeker when it comes to movement. She's very, very active. She's constantly jumping, dancing, moving, crashing. We do a lot of crashing and swinging. But then she's very oral. She's been oral since she was a baby, like everything in the mouth. She's 5.5 and she still chews through most of her toys. She wears jewelry everywhere she goes. And she will for 5 hours straight, just gnaw on it, but it is great. And that she uses some weighted tools to really ground her. But speaking about the hyperactivity or it was interesting too, to listen to, that past 6, that ADHD and emotional disorders. She's 5.5 and with kiddos, with NAS, something that I have run into talking with her developmental pediatrician and her PM&R doctor and her DD caseworker, everybody's like, they don't fit, right? So it's hard for us to find a box for them to fit in. Right. And so then we put them in 15, right? And so she currently has diagnoses of prenatal exposure, ADHD, anxiety, emotional disturbances, and just recently got FASD. And the reality is because NAS is not as currently acknowledged, it's not acknowledged, but it doesn't count for some service for some services or different things. And as much as I hate the fact that she's had to get all these, the diagnoses have come to provide medications and services.
Right.
And so for her to be on an anxiety medication to be able to help with the severe anxiety that she had to have a diagnosis of anxiety, even though a lot of it is coming from the sensory overstimulation and different things. ADHD, same thing. Her team determined, after much time and many other interventions, that medication to help with that would be helpful or necessary. And so it's like she ends up, but everybody says, well, she's got all these diagnoses, but it's a neurologic organic system. So
we hear that for a lot of kids, that we just keep piling on the diagnoses and they don't fit into these boxes, but it meets their needs, or it connects them to interventions, services, supports. We hear that quite a bit. So yes, no, and I like too, you talked about her strengths. It's so easy when we talk about all the risks, but that she has so many strengths and you've been able to accommodate her needs relatively well, it sounds like, and she's doing well. Is there any, and it sounds like early intervention played a role, and I know you gave a lot of suggestions, but if you put your hat on kind of with your knowledge of how, since we have mostly early intervention providers on the call, I always say call, it's really the Zoom, what sort of, maybe if you can think of 3 to 5 sort of tips or things that might help them do their job, help them work with children with NAS and families, what might you recommend?
I would say probably number one, which I feel like a lot of our early intervention providers, pretty much everybody I've ever met, is that connectivity to resources, because we see our kids as much as we can, right? But not always as frequently, especially when they're super little, that getting them connected to the resources that they wouldn't necessarily know about, or if you Google, they're hard to find. So those resources with either, just resources, county resources, or, therapy type stuff that parents don't always kind of understand what it might do. Occupational therapy isn't just for writing.
Right.
But parents don't always know that kind of stuff. Yeah. So I know we talked about it last week, but that's the sleep is huge. Sleep disturbances have been a part of our life for forever. And so kind of really acknowledging how important and powerful that is, and working with the families to help with sleep. And if families are kind of getting to a point where it's just a common thing to talk to their doctors about it, again, when you're talking about really little kids, but if the sleep disturbance is so much that it's affecting the child and the family, something medical might need to be done. I think my daughter has had permanent dark circles under her eyes since she was like 2, because sleep is hard.
Right. It's hard on the whole family. Yeah.
Right. Yeah. Correct.
Yeah.
It affects everybody. And especially if you're thinking about a family. Sorry, the lights just went off in their classroom that I'm squatting in while my office is busy.
It's okay.
Find my way back to what I was talking about. Oh, sleep. I don't remember where I was going. The lights distracted me.
It's okay. No, I know that gets around. So you're saying the resources to the sleep. Do you have one more sort of takeaway for early intervention providers and working with the families and kids that is helpful?
I think this is just a personal experience thing and isn't necessarily related to NAS, but as a parent who has been through early intervention, and you have a child who's beautiful and sweet and smiles and puts on a show when somebody walks in the door, is to really I don't know, I really got messed up by the light, but the like, just believe families, and when they're struggling with something, we always want to believe that parents are accurate reporters and different things, and sometimes we put preconceived notions or stereotypes or whatever, but sometimes kiddos with possibly more hidden disabilities or different things it can be very challenging, especially when you talk about things you don't see, like sleep.
Right.
And different, I don't know what that means. It's been very powerful when we work with people who really acknowledge and are helping, acknowledge what we're going through as a family and what our daughter is experiencing and different things, even if it's not something that they're witnessing, like aggressive behaviors,
Right.
or sleep issues, things that they're not going to see when there's a stranger in their house.
Absolutely. I think that's such good advice. Well, Sarah, thank you so much for sharing your experience, your two hats as early intervention provider and mom. We really appreciate those perspectives and you being willing to share. I'm so glad to hear your daughter's doing so well. I see a whole bunch of thank yous in the chat. And just in the interest of time, since we need to do our case study, Sarah, I'm wondering, there's a few people that just had a few questions for you, specific questions, in addition to their gratitude. Would you be able to just look and yeah, you can see the chat, correct?
I can, yeah.
And reach back out to them. Great. Well,
Yes.
Thank you so much. That's really powerful. We really believe in the power of the family story and perspectives. And you just really, really taught us a lot about best practices. So thank you so much, Sarah. We appreciate it.
Thank you.
All right. And with that, I am going to transition over to my colleague, Dr. Adele Dimian, who is going to do our case study today. And I'm going to start by introducing her. Hi, Dr. Dimian. I see you popped on. Thank you. All right. I have a bio right here and I'm going to read it. Dr. Adele Dimian is a research associate in the Institute on Community Integration in the Tele-Outreach Center at the University of Minnesota campus. Yay. She received her PhD in Ed Psych and Special Education and has a minor in epidemiology. Dr. Dimian co-leads the ICI Telehealth Lab and several telehealth research projects focused on outreach, intervention access, and translational research. Dr. Dimian specializes in early intervention and early development and environmental risks associated with early interfering and self-injurious behavior. Dr. Dimian served as postdoctoral fellow in the Minnesota Lend in the areas of early intervention and telehealth and currently serves as a faculty mentor in the Minnesota Lend program. Welcome, Dr. Dimian. We're happy to have you here. Thank you for doing our case study today.
Thank you so much for having me, and thank you so much for that wonderful didactic, and thank you, Sarah, so much for sharing your lived experience. We really appreciate you being willing to come on today and do that. So I am going to share our case today, and just as a reminder, all the information shared is de-identified. And if you do want to share something from your own experiences today, like during in the breakout rooms, just please remember to de-identify any confidential information. So with that, we'll go ahead to the next slide. So our case today is primarily on three topic areas related to trauma, treatment, and sensory concerns. And this child is 3 years old, and he currently is in a day treatment program. He attends this program and utilizes a preschool curriculum. He is there for half a day, Monday through Thursday, and there are currently 9 other kids and 3 adults in his classroom. So next we'll talk about his background. So go ahead to the next slide. So this child is very emotional and needs ongoing assurance and hugs at times, or some type of physical touch like hugs or holding hands or a pat on the back. He really likes those things. He does have a diagnosis of trauma and stressor related disorders. And he's currently in a kinship home in the care of the county. There was neglect and maternal substance use in his history, and there was also a recent death of a newborn sibling. He has had a hearing screen done recently, and he passed that. So next we'll talk about the strengths that this child has. He's incredibly smart. He could tell you the colors of the rainbow in order, his name, how to spell his name, colors and shapes. He's currently learning how to read books and sight words already. And he's currently on a 5-year-old educational level, and he's only 3. It's pretty amazing. So next we'll talk about the primary concerns with this case. So some common triggers, stressors, or factors related to the primary areas of concern that we'll talk about today in the breakout sessions are that he really struggles with transitions. He will scream, yell, and become overall dysregulated. He also randomly screams throughout the day, and he struggles with participating in class activities, and it is again often described as dysregulated. He runs around, wanders, and often needs one-to-one support to keep him in one area. And when he is unable to get his way, he becomes frustrated that he will start to hit, kick, and scream at times. He struggles with engaging with peers due to this as well, and he can focus and sustain attention. He participates in class activities, sorry about that. And he does have age appropriate speech and doesn't currently have any speech services that he is receiving. And when he speaks to others, he is easily understood. So next, we'll walk through the strategies or interventions that he currently receives. He does receive individual therapy 1 time a week, or depending on his needs. There is a mental health clinician in his class with him every day assisting with behavior needs and providing interventions such as modeling, coaching, providing reassurance, and working on social skills and social communication. He receives occupational therapy and physical therapy weekly. Some of the strategies they are currently using include visual schedules, first then boards, timers, and there also is a really nice safe place in the classroom that he can use whenever he wants to help him calm down if needed. And he's really in a structured environment when he is at this setting. So overall, the goal for this case is for this child to be able to transition appropriately and use his words to vocalize what he wants and needs. So now we're all going to transition together into our breakout groups. So remember, in the breakout groups, please unmute yourselves and use your video to communicate with others, or you can use the chat. We'll reconvene in about 10 minutes. I'm going to review these questions before we let you go into those breakout rooms. But please remember to nominate at least one person for your group to write and share your recommendations with us. We will have you put them in the chat, and then I will go through them together when we reconvene in about 10 minutes. Remember, if you're on a mobile phone and can't access the breakout rooms, we will remain in this main Zoom room, so feel free to just hang on there and talk with us if need be. So the 3 questions today that we want you to discuss in your breakout rooms and as part of this Project Scope Learning Collaborative are, number 1, how to better support him in the classroom. Number 2, what new interventions could you try? And number 3, would referring for a psychological or a psychologist be appropriate? So those are the 3 main questions that you'll talk over with the group. Again, feel free to let us know if you have any questions or concerns. We'll be here and we'll go ahead and break you out into those groups now. Thank you. Welcome back, everyone. I hope you had some good discussions. Just pull up the chat here. So if somebody wants to get us started with what they talked about, okay, great, thank you, Lynn. Looks like Lynn's group discussed helping him in the classroom, working on having him advocate for taking a break, excellent. Once he can do this, give him choices of what he wants to do, great. Also, do the psychology evaluation. If the parents are interested, this may open up other opportunities, yes. Group 3, thank you for putting yours in the chat. There's included an ABC charter FBA being conducted, asking when these behaviors are happening, doing a thorough analysis of the environment, looking particularly at some of those sensory types of stimuli in the environment as well, using social stories, asking if he's bored or needs more academic stimulation, regarding interventions, developmental repair, and emphasis on kindness and co-regulation, and then referring to another psychologist. What would the family in school be hoping to get from this? Thank you for sharing those. Group 3, Molly, thank you. Any other groups, feel free to come off mute if you'd like as well. I think we had 2 more groups, is that correct, Courtney? I know it's towards the end of the day, so people might have to leave for daycare pickup or whatnot. So I understand if people had to run. Go ahead, Courtney.
Oh, nope. I was just going to say, I think there were 2 more groups, but totally understand if people had to leave.
Yeah. Oh, they got left in the breakout room. Sorry about that, Lisa. So offer more sensory or calming strategies. Yeah, our group talked about that too, like how you can kind of proactively teach him some coping strategies when he's calm, before he's escalated. And environmental considerations. Yeah, how can you change the environment to be a little bit more calming possibly for him, or times of day that are particularly difficult. Social stories, so that's a common one. I think we can definitely include that as one of our summary recommendations. Turn taking with peers. Yeah, we talked about this too in our group. Just, there wasn't a lot of information, but how is he interacting with peers? What does the attachment look like with his other providers and people in his family? What are some ways that we can encourage some social skills between him and others? And then visual schedules and timers. Yep, great.
Yeah, so many great ideas. Thank you, everyone. Adele, is there, or does anyone want to say anything? I don't want to rush us through, but I know it's the end of a very hot day. My office is very cold right now, but I know that's not the way it is for everyone. But does anyone have anything else they want to share? Well, we'll summarize those and get those together and share them out with the group. There are so many good suggestions here. Thank you, Dr. Demian. We really appreciate it. And Courtney is driving the slides, and I'll just do the summary at the end, and then we will be done for the day. Courtney, is there the one with the, oh yes. So everyone, you know the drill in terms of what happens next. You will receive an evaluation certificate of participation. You'll get an email to complete a REDCap survey about this session. Minnesota Project Scope does offer certificates of participation, but you just have to do your evaluation, and then we will send a certificate of participation after you complete the feedback survey. Thank you so much for doing that in advance. And next slide, please. Our next week is going to be another really great session. We hope to see all of you Tuesday, June 15th. The topic is the child welfare system impact in Minnesota. And we will have Lisa Bailey from the Minnesota Department of Human Services. It should be good. Thank you so much to all of our partners again, Minnesota Lend, Project Scope, ICI, the Institute on Community Integration, the Minnesota ICI Telehealth Outreach Center, and the Minnesota Act Early Project, as well as all of our state agency and clinic partners. We so appreciate all of your support. And thank you. That is our final slide. I hope everyone has a lovely night. It was so great to see all of you. Be well and stay cool. We'll get through this heat. Hopefully next week will be nicer weather. And for those of you finishing your school year, have a good end of the school year. And we look forward to seeing many of you next week. Thanks a lot. Have a great night. Bye-bye.
I think it's just us now.
Yeah, I think it is just us. Yay.